4. Clinical features and presentation. There are many aspects to BBS, and it is important to remember that there is great variation among those affected, even between siblings. The following section looks at each aspect in turn and includes recommended tests and assessments. Eyes. Pigment changes similar to those in retinitis pigmentosa are often seen upon examination of the retina in individuals with BBS. The correct term is rod cone dystrophy. The light-sensitive photoreceptor cells in the retina, the rods and cones, degenerate over time because of defective cilia. The rods provide night vision and peripheral vision, and the affected individual will experience poor night vision and loss of peripheral vision as the rods degenerate. The cones provide color vision and central vision, and as they degenerate, color and detailed vision will be impaired. The onset of rod cone dystrophy is usually noticeable during primary school years and is initially experienced as difficulty with seeing at night or in poor light conditions. In some cases, however, visual symptoms can be delayed into the late teens or beyond. As the retina degenerates and the condition progresses, the affected individual may lose some ability to see through the whole visual field. Loss of peripheral vision is frequently referred to as tunnel vision. As the visual fields close in, the young person may begin to appear clumsy, especially at night time. Functional vision will also be affected by changes in lighting and low lighting. Dark evenings will make it more difficult to use residual sight, and daytime glare will affect central vision. A study found rod cone dystrophy present in almost all patients who have a genetic diagnosis of BBS. A significant number of people with BBS have retinal signs that are seen on examination of the retina. However, in some, the retina can appear normal, and electrodiagnostic testing is needed to provide evidence of retinopathy. A study found that the average age at which symptoms or signs of visual loss are reported is 12 years of age, although night blindness was often noted earlier. The study also found that the average age of registration of blindness is approximately 15 years. Other eye conditions associated by BBS include wobbly eyes, nystagmus, an irregularly shaped cornea, astigmatism, squints, strabismus, glaucoma, and cataracts. Treatment. Research is ongoing regarding the possible effectiveness of gene therapy to treat rod cone dystrophy in BBS. It is possible that there may be research projects over the next few years for a small number of BBS patients to see whether the treatment is safe and beneficial. In the meantime, correction of short or long-sightedness and astigmatism, and the provision of tinted glasses for light sensitivity can assist in maximizing usable vision. Cataract surgery should be offered where appropriate and where it will be of actual visual benefit. Low vision aids and mobility training can improve independence and confidence. Magnifying glasses, digital systems, and voice systems may also be helpful. Consideration should be given to educational planning, and if there are disrupted sleep patterns and difficulties with breathing at night, nocturnal apnea, sleep studies should be considered. Referrals to local low vision clinics and organizations assisting the visually impaired are recommended. Partial sight and blind registration, certificate of visual impairment, should be carried out in the first instance where any visual impairment is diagnosed. Visual assessment. At diagnosis, visual acuity assessment and refraction, visual field testing, examination of the back of the eyes, electrodiagnostic testing, and OCT scanning. Follow-up yearly eye examination, visual acuity, visual field testing where possible, examination of the back of the eyes, electrodiagnostic testing if indicated, screening for cataract, glaucoma and diabetic retinopathy as appropriate, and general eye health check by local optician between hospital appointments. Signpost: Retina UK, www.retinauk.org.uk, 0300 111 4000. RNIB, www.rnib.org.uk, 0303 123 9999. Victa, www.victa.org.uk, 01908 240 831. Look, www.look-uk.org, 07464 351 958. And Sense, www.sense.org.uk. Obesity. Obesity is reported in 72 to 86% of patients. Weight issues usually begin in childhood and increase in severity with age. Children may exhibit rapid weight gain, with 1/3 of babies developing obesity by their first birthday. Controlling rates of weight gain during the first years of life can be challenging, especially when crawling or walking is delayed. However, some children do not present with weight concerns until puberty and final adult height is achieved. Most adults who have BBS have a BMI greater than 30, which is often accompanied by other health issues, for example, high blood pressure, high cholesterol, and type 2 diabetes. Hyperphagia, excessive hunger, and food-seeking behavior are common, resulting in energy intake exceeding requirements, which makes dietary management challenging. Treatment. BBS symptoms cover a wide spectrum and vary significantly between individuals. It is important that all patients have an individual assessment of their weight and dietary requirements. Understandably, diet and weight concerns are a major source of stress for patients and their families. The knowledge that untreated obesity can lead to multiple health problems, for example type 2 diabetes, coronary heart disease, liver disease, and metabolic syndrome, adds to this stress. Unfortunately, there is no single treatment approach for obesity in BBS, just as for obesity in general. But those with BBS can successfully lose weight. In younger children, care should focus on controlling the rate of weight gain without compromising growth. A healthy, balanced diet and active lifestyle approach is encouraged. Establishing routine meal and age-appropriate snack times and portion control strategies are important to manage the excessive appetite that can be associated with BBS. Very low-calorie diets are not required, as this over-restricts energy intake. It is important to educate with dietary strategies and encourage activity to control weight gain in childhood, so these behaviors can then be continued into adulthood. A multidisciplinary approach is needed and should include dietary advice, behavioral management, and exercise. Early referral to a registered dietitian with experience of BBS is important, and attendance at the multidisciplinary BBS clinics is strongly recommended. Research continues into therapies to target obesity in BBS. The latest research developments are discussed at the BBS UK Annual Conference and can also be accessed via the BBS UK website. There have been widely publicised developments in the drug treatment of obesity, with clinical trials ongoing and treatments becoming available. For any medication, there will be criteria that need to be met for this to be available on prescription, and monitoring required to ensure safe use. Patients and families will be updated on any available drug treatment within their BBS clinic appointment and via BBS UK. Surgical management approaches for obesity are not recommended, as these procedures do not address hyperphagia. The associated risks and benefits of bariatric surgery options need to be considered for a person living with BBS. It is important to note that specialist dietary advice and support is needed post-surgery, and compliance with these dietary restrictions is imperative. Patients and families are encouraged to discuss the latest treatment options for obesity and hyperphagia with their clinic team at their next BBS appointment. Polydactyly and brachydactyly. Most BBS patients, 70 to 84%, are reported to have extra digits, polydactyly, most commonly appearing next to the little finger or toe. Presentation ranges from a single skin tag to a fully formed digit on all 4 limbs. Shortness of the fingers and toes, brachydactyly, is common, affecting 46 to 100% of patients, and is more frequently found in the feet than in the hands. When present in the hands, it may affect dexterity and the ability to use keyboards or braille. Webbing, syndactyly, is less frequently seen and is usually partial and generally confined to the feet. Treatment. Skin tags can be tied off at birth after documentation by a medical practitioner. Fully formed digits are often non-functional and should be removed where possible within the first year of life by either an orthopedic or plastic surgeon. Bony malformation in wide feet can lead to ill-fitting shoes, and it is important to seek podiatric and other orthotic advice and specialist fitting. Renal. BBS can affect the kidneys in a number of ways, although significant kidney problems and kidney failure are seen in only a small proportion of patients. Nevertheless, it is important to monitor all patients regularly. Most patients with BBS do not have any serious kidney involvement. More than half of patients with BBS have kidneys that are a slightly abnormal shape or size, and they may have kidney cysts. However, these abnormalities seen on a kidney ultrasound scan hardly ever get worse or cause any problems. When kidney problems do occur, they usually cause mildly impaired kidney function, protein in the urine, and high blood pressure. For these reasons, blood and urine tests and ultrasound scanning of the kidneys should be a routine aspect of renal management in BBS. A minority of patients with BBS experience more severe kidney problems that may lead to a significant reduction in kidney function or kidney failure, requiring dialysis or a kidney transplant. Fortunately, this is uncommon. A review of kidney involvement in 219 BBS patients seen in the specialised BBS clinics in the UK noted that only 6% of these patients had developed kidney failure requiring dialysis treatment or kidney transplantation. It was also noted that 5 out of the 12 patients with kidney failure developed it in the first year of life, and these were all patients that were born with severe abnormalities in their kidneys. The remaining 7 developed kidney failure later in childhood, probably reflecting less severe congenital abnormalities of the kidney. The encouraging news from this review is that patients who do not have any evidence of kidney abnormalities in early childhood are very unlikely to develop severe kidney problems later in life. It is important to understand, however, that with advancing age, other factors such as obesity, diabetes, hardening of the arteries, and high blood pressure may also contribute to a decline in kidney function. Those patients who do develop kidney failure seem to do well with dialysis and kidney transplantation. So even if kidney failure does develop, there are very good treatments to support patients. Other kidney problems may occur in BBS, including a reduced capacity to concentrate the urine. This leads to higher than average urine output and sometimes excessive thirst, although few patients notice this. Infections of the bladder, cystitis, and occasionally of the kidneys themselves can also occur, and are treated in the conventional way with antibiotics. Clinicians working in the BBS specialised clinics have also recognised that it is quite common for patients to hold on to their urine and pass large quantities just a few times a day, whilst others wake up to pass urine frequently through the night. Holding on to urine for most of the day can lead to stretching of the bladder and cause problems to develop later in life. Patients can avoid this by ensuring they empty their bladder frequently, for example, by going for a wee when they wake up, after meal times, and before bed, whether they feel the urge to go or not. High blood pressure may be evident in patients with kidney disease of any type, and in BBS it is often present and should therefore be regularly checked and treated if necessary. High blood pressure can also put further strain on the kidneys, so in BBS patients, where there is known kidney involvement, it is particularly important to monitor and treat this. Obesity is a very common problem in people with BBS, and excessive body weight can put additional strain on the kidneys and make high blood pressure worse. This can exacerbate any underlying kidney problems, or can even occasionally cause kidney damage on its own. The reasons for managing weight in BBS therefore extends to protecting the kidneys from damage. Renal assessment. At diagnosis, check symptoms of anemia, polyuria, and polydipsia. Baseline blood pressure assessment, 24-hour blood pressure monitoring if there are concerns and if possible. Measure plasma creatinine, urea, electrolytes, GFR. And bladder and renal ultrasound examination. Follow-up, yearly for symptoms baseline blood pressure. Yearly early morning urine analysis for albumin-creatinine ratio and dipstick testing for microscopic hematuria. And yearly monitoring of plasma creatinine, urea, and electrolytes, GFR. Signpost. National Kidney Federation, www.kidney.org.uk, 0800 169 0936. Kidney Care UK, www.kidneycareuk.org, 0808 801 0000. And PKD Charity, www.pkdcharity.org.uk, 0300 111 1234. Quote, "When I was 16 I went to the West of England College in Exeter. At the college I learnt how to be independent, doing things such as cooking, cleaning and shopping. I also completed courses in further education, including an NVQ in administration. I also did work experience placements. I love living independently and being able to see my friends and go where I want to. I feel that I have achieved a lot so far in my life, and I look forward to enjoying life to the full." End of quote, patient. Development, learning, social and emotional well-being. BBS is a condition that has a wide spectrum, and so each person will be affected differently. Some children and adults will have few developmental or learning needs, whereas others may need ongoing support throughout their lives. Like all children, those with BBS will generally continue to progress and learn throughout their childhood. Each individual child will have their own strengths and personality and follow their own unique path in learning and development. This section will talk about the range of difficulties that can occur for children and adults with BBS. This does not mean that each person will experience all of these difficulties. It will be important, however, for parents, carers, school staff and others around an individual with BBS to understand their strengths and needs in order to help them achieve their potential, to be themselves, and to enjoy life together as part of a family. Learning and academic ability. Children with BBS show a wide range of developmental and learning abilities. Studies to date show that most children with BBS have some degree of learning needs and may benefit from additional support at school. Children with BBS often perform below the age-expected range on cognitive assessments, but there is variation, and some children perform within the average range. A number of children will meet the diagnostic criteria for a learning disability, and previous research estimates of the rate vary widely between 25 to 66%. A recent study in a clinical sample of children with BBS in the London BBS clinic service found that 9 out of 21 children who were assessed, 41%, met diagnostic criteria for a learning disability, Bloomer et al. In Press. The exact rate is difficult to confirm due to the study having a small sample size and not including all children in the service, meaning we cannot be sure how representative it is. A learning disability means that someone shows consistent difficulty with learning new information, understanding concepts and ideas, low intellectual abilities, as well as difficulty with everyday activities, for example carrying out chores, personal hygiene, and staying safe in the community. It affects people their whole lives. A learning disability is diagnosed by a health professional, usually a pediatrician or a psychologist. A learning disability is different from learning difficulties, a term that is used to describe specific difficulties with learning that can be for a range of reasons, but do not meet the criteria for a diagnosis of a learning disability. Whilst children with a learning disability learn and develop throughout their childhood, they do so more slowly than other children of their age, and will require support for some tasks which other people their age may be able to do independently. Someone with a mild learning disability may be able to complete most tasks independently and only require support with complex tasks, like filling in forms or managing financial decisions. Whereas some with a more severe learning disability may require support with daily living. Most people with BBS who have a learning disability are at the mild to moderate end of the spectrum. Clinical assessments undertaken within the BBS clinic service have shown an additional pattern of weakness with motor skills, as well as a shorter attention span for people with BBS. These areas may also impact on their learning and participation. It is important that people working with children with BBS allow the child enough time to interpret and understand information and provide answers. This will allow children to show the best of their abilities. Children with BBS show a wide range of learning abilities and support needs. Many children with BBS attend mainstream schools, and some attend specialist schools depending on their needs. Some children are very academically able and will go on to university education. Visual needs and learning. Regardless of the school setting that a child or young person is in, if they have any visual needs, these will influence how they need to access learning in the school setting. Regular vision assessments and timely support from vision specialists is needed, as a young person's visual needs change over time, so the support they receive will need to be adapted. As these visual changes occur, consideration of learning new skills will be important, especially as the young person becomes more independent. Information about supporting children and young people in a learning environment can be found in the BBS UK booklet for schools and colleges. Social communication and autism spectrum. It is known that children with BBS often show differences in how they communicate and understand social situations. Children may also behave in a way that appears obsessive and rigid. Recent studies suggest that around 70 to 80% of children with BBS will show autistic tendencies, with an overall estimate of 34% diagnosed as being on the autism spectrum. Therefore, social communication needs will be important to consider during childhood, adolescence, and into adulthood. Emotional and behavioural needs. As can be expected for children with learning, language, visual, and social communication needs, children with BBS are more likely to show emotional and behavioural challenges. For young children with BBS, it is important to be mindful of their emotional well-being and consider what may be behind any behavioural challenges they show. Typical behaviour management strategies may not be effective, and specialist support from local health services may be required. Setting clear boundaries around food and eating at an early stage may help to prevent future difficulties in this area. Towards the later years of primary school, some children with BBS may show an increasing awareness of their needs, which can lead to the feeling of being different, particularly in the school setting. At this age, young people may experience difficulties with friendships and bullying, which, alongside weight issues, can result in low self-esteem. Helping children and young people to recognize and appreciate their own strengths, as well as developing their interests, can protect against such difficulties. As a young person gets older, they and their family often experience fears and worries relating to the daily management of any behaviour difficulties, education, living an independent life, and relationships. Fitting in socially is very important, and the teenage years are when relationships and sexuality are important issues that young people may explore. This stage of development involves the young person exploring their identity as being separate from their parents, and so they may want to spend more time away from parents. As with the general population, hormonal changes can also contribute to developing emotional difficulties, with people feeling lonely and unhappy. In adulthood, anxiety is commonly reported, which can significantly impact on the individual's ability to cope with their condition. Common concerns include worrying about health and medical needs, not feeling in control of emotions, apathy, and finding employment. Individuals with autism or autistic traits may have difficulty understanding other people's emotions and difficulty reading social cues, which makes it harder to relate to others, leading to social isolation. A combination of differences in social abilities, alongside changes to daily routines when young people leave education, can lead to feelings of anxiety. People may struggle with uncertainties, including the loss of routine and relationships, as well as increased unpredictability about the future. Independence is an issue for some, but not for others. Some people may find employment, whereas others find themselves understandably frustrated about the limitations that can come with BBS. Specialist support will continue to be needed for adults with visual, learning, and social communication needs. Low mood, panic attacks, obsessions and compulsions, anger, and poor emotional control also commonly affect adults and young people with BBS. It is unclear whether this is a part of the syndrome or an indirect result of it. Most likely it is a combination of both. A very small number of patients experience delusional thoughts, and some develop periods of psychosis. If this is suspected, prompt referral for a psychiatric opinion and therapy is warranted. Support and management. For young children of preschool or school age, an Education Health and Care Plan, EHCP, will ensure the child is fully supported. Parents or carers should contact the school or preschool and request an assessment be commenced. The school or preschool's SENCO, Special Educational Needs Coordinator, will coordinate the process and arrange for educational psychologists and sensory team involvement. Possible interventions for children would include assistance with school integration, behaviour support, speech and language therapy, qualified teacher of children with visual impairment, family support, management of symptoms, sensory support, exploring emotional needs, and occupational therapy. Due to the high level of learning needs and social communication differences in children with BBS, it is important for children to access assessments if concerns are identified. It is important that needs are identified during childhood and adolescence. Assessments can identify whether children meet the criteria for a learning disability or autism diagnosis in order to access further support. For adults, isolation can lead to or exacerbate anxiety and depression, and it is vital that appropriate support is in place. If there are concerns with an adult's mental health or emotional well-being, they may benefit from accessing psychological or psychiatric support. Referrals for support can be made through the GP. For adults with BBS who also have a learning disability and/or autism, there are specialist NHS services to support with mental health, tailored for people with learning disabilities. Referrals to these services can also be made through the GP. There are many ways for adults to access support. A. Ask GP to arrange a social services assessment and occupational therapy assessment. B. Ask GP or social worker about local support groups for the disabled or visually impaired. C. Ask GP about counselling or psychological intervention if more support is needed for low mood or anxiety. D. Talk to staff at a local disability centre or social worker about activities in the area. E. Contact BBS UK for advice or support. It may help to talk to others in the same situation. F. Exercise is vitally important for emotional and physical well-being. And G. Local disabilities team or social worker will be able to help with claiming benefits, arranging support workers, carers or respite, and linking individuals into local services in the area. Signposting for people with BBS. Mind. www.mind.org.uk 0300 123 3393. National Autistic Society. www.autism.org.uk. MENCAP. www.mencap.org.uk. Scope. www.scope.org.uk 0800 800 3333. And the Challenging Behaviour Foundation, www.challengingbehaviour.org.uk 0300 666 0126. Endocrine. Male reproductive system. Hypogonadism, lack of production of sex hormones, is common amongst males, affecting up to 30% of BBS patients. A small buried penis with reduced volume testes is common. 10% of male patients with BBS have undescended testes at birth. In most cases, this is due to a partial failure of the hypothalamus and/or pituitary gland with low or inappropriately normal luteinizing hormone LH and follicle stimulating hormone FSH with low circulating testosterone levels. In a small number of individuals, there may be primary testicular failure. There is usually enough testosterone production to permit normal pubertal development. The timing of male puberty is often slightly delayed, but with normal progression and secondary sexual characteristics. Puberty can be a particularly stressful time for individuals with BBS, regardless of their sex, and where possible, referral to a counsellor with experience in this field can be of help. Adult male patients with hypogonadism may be prescribed testosterone replacement by an endocrinologist. This may take the form of either injections or daily gel preparation. While this may help with sexual function and libido, an important benefit is likely to be the preservation of bone mineral density and reducing the risk of fractures. Although affected males may be infertile, several have fathered children. Female reproductive system. Hypogonadism is much less frequent in women. However, structural anomalies of the female genitourinary tract are documented, including vaginal atresia, abnormally closed or absent vagina, hydrometrocolpos, collection of watery fluid in the uterus and vagina, ectopic urethra, urethra that terminates somewhere other than the bladder, hypoplasia, underdevelopment of the uterus, ovaries and fallopian tubes, and septate vagina, vagina that is divided. Large ovarian cysts have also been found in prepubertal girls with BBS. Girls with BBS tend to go through puberty at the normal time, and although there is little evidence to suggest secondary hypogonadism, contrasting with men, polycystic ovary syndrome, PCOS may be present in up to 20% of women with BBS. This can lead to problems with menstrual irregularity, acne, and excessive hair growth, notably on the face. For those patients who are considering fertility, polycystic ovary syndrome needs to be considered should there be a delay in the onset of menstruation or with conception. Several females with BBS have given birth successfully to healthy children. Thyroid function. Thyroid function tests are normal in most patients with BBS. However, approximately 25% of patients may have thyroid test abnormalities. Most commonly, this is an underactive thyroid gland, hypothyroidism, which can cause tiredness, lack of energy, feeling cold, constipation, and difficulty in losing weight. In the majority of cases, this is a very mild abnormality, often termed subclinical hypothyroidism, and may not require any treatment. In some individuals, however, thyroid hormone replacement treatment is needed. Patients with BBS should have an annual blood test to measure thyroid function. Signpost. Patients affected by any of these issues should speak to their GP for a referral to an endocrinologist and/or counsellor where appropriate. Patients of the BBS multidisciplinary clinics should speak with their endocrinologist or BBS clinical psychologist. Diabetes. The risk of diabetes associated with BBS increases with age, as it does in people without BBS. As such, accurate estimates of the risk of diabetes are difficult to make, but depending on age, it is seen in 6 to 48% of people living with BBS. It rarely presents before adolescence, and in this age group occurs in those with the highest BMIs. A higher proportion of patients may have abnormalities of glucose tolerance, and regular screening for the development of diabetes is recommended. The underlying BBS ciliopathy and high BMI contribute increased risk factors for diabetes mellitus. This can be controlled with combinations of diet and medicine, including metformin and insulin. Newer therapies, for example GLP-1 analogues, DPP-IV inhibitors, and SGLT2 inhibitors, are also potentially useful to try to optimize glycemic control. Regular diabetes assessments are important and should be carried out at least annually. Preventable diabetic retinopathy can lead to rapid deterioration of vision already compromised by the rod cone dystrophy. Alongside monitoring for complications of diabetes, it is important to control blood pressure adequately, and all patients with diabetes over the age of 40 should be considered for lipid-lowering therapy. Both measures are aimed at decreasing long-term cardiovascular risk. Endocrine assessment. At diagnosis, measure height and weight, calculate BMI. Hormone levels, including testosterone, gonadotropins FSH, and LH, over 8 years in girls and 9 years in boys. Pelvic ultrasound examination, females. Liver chemistry, including AST, GGT, and ALT. Fasting lipid profile, including triglycerides. Fasting plasma glucose, FPG. Glycated hemoglobin, and thyroid function tests, including TSH and free T4. Follow-up, at least annual but may be more frequent, measurement of weight, height, and calculation of BMI. Annual thyroid function test, including TSH and free T4. Liver chemistry, including AST and ALT. Fasting lipid profile, including triglycerides. And fasting plasma glucose or glycated hemoglobin. Signpost. Diabetes UK. www.diabetes.org.uk 0345 123 2399